Okay, so we are going to do a little didactic session down here at the South for the South Campus service. The videotape, again, is for the benefit of those of our team who couldn't be here and anyone else who's interested in watching. Specifically, that means Dr. Fennell. Almost done, man. Hang in there. And Dr. Tran, who's currently in clinic with one of our faculty members. The mutually agreed upon topic that we were going to discuss this week is cirrhosis, and specifically the sorts of things that we have to think about when we are contemplating operating on cirrhotics. So let's start with what is cirrhosis? Anyone can answer. Specifically with reference to the liver. It's fibrosis. That's right. So, what are the pathologic characteristics of a cirrhotic liver? So fibrosis and one other pathologic characteristic. When you're reading an ultrasound read or a CT read on somebody with cirrhosis, what do they say about the liver? How does it appear? Nodular. Okay, so that's the other pathologic characteristic of liver cirrhosis. It's regenerative nodules. So the liver's trying to regrow itself. The liver has this uncanny ability, unlike any other organ in the body, to essentially repair itself or regenerate itself. And cirrhosis represents, or that nodularity represents the liver's attempt to regenerate itself after constant damage that is the result of any number of factors. So, what in this country, what is the most common? What is the most common cause of cirrhosis? That's not true. It used to be true.
Fatty liver.
Fatty liver, but that's a little too non-specific for me to give you credit for it. There you go. So NASH, or non-alcoholic steatoreic hepatitis, right? And that is, it is associated with obesity. That doesn't necessarily mean that it's caused by obesity, but there does seem to be a clear association between obesity and NASH, and it tends to run along with other comorbidities that also tend to accompany obesity, such as diabetes and hyperlipidemia and those sorts of things. So the mechanism there has not been fully worked out, but it is actually now by far the most common cause of liver cirrhosis in the United States. So what's the second most common cause? So alcoholic, right? And one of the responsibilities of the liver is to process the alcohol that's consumed orally, and I suppose alcohol that's consumed IV as well. Although, yeah, I'm not sure how that would work. But correct. You know what? There were people who were doing those Four Loko shots. Hey, what they do in the privacy of their own home ain't none of my business. What's the third most common cause? So it's the viruses, right? So hepatitis C is actually a more important cause, and why is that?
Because I think it was like transfusions back in the day.
It's more backdoor, right? So hepatitis B, we've had a vaccine for some time. So all the people at the highest risk of contracting hepatitis B have now been vaccinated against it. So hepatitis C is number one, it's a more common virus, right? So about what percentage of the population is infected with hepatitis C? That's not quite that high. It's about 4%. About 4% of the population carries hepatitis C. Thank God, because hepatitis C is a vicious one, right? So what are the clinical manifestations of cirrhosis? So coagulopathy, sure.
Fluid retention. Like ascites.
So ascites. What else? Spine angiomata. What else? Say again. I was not aware of that. So they can get gynecomastia, sort of the same mechanism. Pulmonary edema. You guys are missing a big one. What's that? So varices, not the line on jaundice. So jaundice is an important one. What other any other physical manifestations of cirrhosis?
You said varices,
Hemorrhoids.
Yeah.
So yes, and I think the converse is also true. So you can actually get hepatitis. There's something called a congestive hepatopathy, which is the result of result of right heart failure that leads to congestion of the IDC and resultant congestion of the liver that can actually lead to a very respectable transaminitis and elevation in the INR. And so what is the best immediate test of the function of the liver? PT-INR, right? So PT, and what is that? Remind me, what is the INR? What is the INR?
Oh, like in these patients?
No, what is the INR?
Oh, just the internal normalized ratio.
International normalized ratio. What does that mean?
It's like a comparative of PT for normal PT to patients that have normal PT across.
To an internationally accepted standard, right? So a normal INR, quote unquote normal INR, is going to be 1, right? Above that, we've got a problem, right? There's some sort of coagulopathy there. So, what is the most reliable test of depressed liver function in terms of severity? It's a tough one. Do you know?
So you're saying what's the most, if this is elevated or abnormal, it's the most indicator of the more severe disease? Is that the question?
It's an absolute test of the function. So the INR is a test against a ratio, right? An international standard.
Right.
What test do we that is not a comparison? That basically, if this lab is abnormal, it suggests significant liver dysfunction.
Right.
So the lab I'm looking for is something called a factor 5 assay. It's also a factor 10 assay, and essentially what it's looking at is the liver's ability to manufacture a protein that is specifically and only manufactured in the liver. And if that's depressed, it's a send out. It takes 2 to 3 days to get it back. It's almost never used, but it's actually the best study of the absolute functionality of the liver. What do we all use? We use the INR, right? The INR is our best indicator of how functional a cirrhotic's liver is. So let's go into what are the concerns what's a primary concern that a surgeon might have in treating and performing surgery on a cirrhotic? What's that?
Bleeding.
So bleeding, right? And so the bleeding question in cirrhosis is actually multifactorial. So first, there's a depression of the primary coagulation cascade because of the liver functionality, and so what's the second issue? And platelets. So let's spend some time unpacking why that's even an issue in surgery. So what in somebody who's got cirrhosis, what what do we expect to see in their platelets? Is there an abnormality in their platelets or no? Say again. One more time. Target cells. No, I mean, so you send off a CBC, and that CBC comes back with a value for your white blood cell count, your hemoglobin, your hematocrit, and platelets. Those are the four that we worry about. So let's say somebody has cirrhosis. I will always get a CBC, and I'm looking at a specific number, and the number is platelets. So what do we expect to see in the platelets in somebody who's got cirrhosis? Say again?
Just like
A low count. Let's use a doctor word for that. We expect to see a thrombocytopenia, right? So what is the mechanism of the thrombocytopenia? Help me understand this.
So, fibrotic fibrosis of the liver results in venous congestion. Drainage of the spleen is largely through. So, the portal vein is the populace. So it creates a splenic vein, SMP. It's created. So, that congestion, now the spleen becomes congested and sequesters too many lipids.
That's exactly right. So for our viewers who are watching at home, the fibrosis of the liver makes it more difficult for blood to pass through the liver in its filtering capacity, and that results in increased pressure in the vessel that is feeding the liver. And what is that vessel that is feeding the liver? That's the portal vein. That's right. So what do we call increased pressure in the portal vein? We call that portal hypertension. That's exactly right. So really the question about thrombocytopenia, it's an anatomic question. So what are the two vessels that coalesce to form the portal vein? Dr. I.M. Kessler just said it. It's the superior mesenteric vein and it's the splenic vein, right? And if there's increased pressure in the portal vein, what's the pressure in the splenic vein and the superior mesenteric vein? So you've got hypertension in those veins as well, right? So what is one radiographic and clinical manifestation of portal vein hypertension that's often seen in cirrhotics? And in fact, it was the basis for a study that we used to get called a liver spleen scan. Splenomegaly, right? So you get considerable splenomegaly. So what is actually contained within the spleen? What is the job of the spleen? So the non-immunic job, the immunologic job. So the immunologic job is that the spleen is that it performs or it produces opsonins and what's its hematologic job? Filters the blood. So what happens to all red blood cells? What do we do with them? We just let them float around. Yeah, we break them down. Where do we break them down? The spleen, right? And what happens to all platelets? Same sort of thing, right? So they pass through the spleen, and if you've got high pressures in the splenic vein, what is not happening to those platelets? They're not making it out of the spleen, right? So I'll ask you again: what is the underlying mechanism for thrombocytopenia in patients with portal hypertension? Splenic sequestration, and that's the important word to remember. So these patients, they have the platelets. the platelets are simply not available within the circulatory system. They're not being picked up on our labs. The problem is they're stuck in the spleen. They can't get anywhere. So we had mentioned one clinical manifestation of cirrhosis as being esophageal varices. So my question is, are esophageal varices, are they truly a manifestation of cirrhosis, or what are they actually a manifestation of? So the portal hypertension, right? So portal hypertension, because we don't necessarily treat the cirrhosis, mostly because we don't have a good treatment for cirrhosis, right?
Sure.
What's
Transplant.
transplant? So we can transplant them, but what if they're still drinking? What if they're not going to get? Does that mean they just don't get treatment for their esophageal varices?
There's a bypass that, but I think it's risky.
So let's talk about this algorithmically, because I've done exactly one of. There are several of these shunts, and in my career, which now I started residency or medical school in 2002. So my medical career in aggregate now runs 18 years, and in those 18 years, I've seen exactly one surgical shunt, just one. And that was a portal venous shunt. So what are our other options for improving portal hypertension?
Well, that's what I was thinking. If they're severe, they're going to get B7. So then if everybody
What's that?
14,
TIPS procedure. What's a TIPS
you're
procedure?
already out 21 days, right? So if you just said, if you get hospitalized, you have to be 14 days out. And otherwise, it's the same that we're talking about.
So what's it called?
I've been out for like a month. Yeah, I guess. I just haven't seen
Transhepatic
anybody with like severe.
portal venous shunt.
We just classify it the
Right,
same
so,
way we just did.
And the idea is you are creating an artificial connection between the portal system and
I guess it's possible,
the main
I
venous
feel like
system,
that
right?
would be
So,
pretty much
um,
secure if we-
so
if they're gonna do
have you got how do they measure whether or not a TIPS procedure has been successful? What are they measuring?
No.
Do you know?
What are the measurements to see whether it's successful?
Yes.
It should be portal pressures, right?
So yes, ultimately it's pressures, but you're looking for a gradient, right? So a gradient is the difference between two different pressures, right? So at one side of the gradient is the pressure at the start of at the start of the shunt, and the pressure at the end of the shunt. So you're looking for a gradient of 6 to 10 millimeters mercury, and so that might be something that you're asked about. It's worth knowing about, and so. So TIPS is a very, very useful sort of thing to have in your back pocket. So twice in the last year, I've encountered individuals who had cirrhosis and had, for whatever reason, permanent colostomies created years ago, and were now having what appeared to be variceal bleeding from their ostomy sites. And of course, they were sent to me because everyone thought that I would rush in and operate on these cirrhotics with portal hypertension. Which was I was sorry. Well, I was not sorry to disappoint them. But I referred both of those patients for TIPS procedures, and neither of those patients made it back to me, which is perfect. That's a win, right? So, what are the downsides of TIPS? What's the primary downside of TIPS? Encephalopathy, right? So it can exacerbate encephalopathy because you're essentially bypassing the liver, right? There is any residual filtering activity of the liver has now been eliminated, right? So it can worsen encephalopathy. It can worsen something else as well. It can worsen ascites, yeah. So that is also a downside of ascites. So let's talk about the ascites. What is the etiology of ascites in people with cirrhosis? So it's low albumin. That's right. So albumin is one of the primary osmotic drivers, or one of the primary drivers of the osmotic pressure of serum. Correct. So if you reduce the albumin content of the serum, that is going to drive fluid out, right, into the peritoneal cavity, right? So how do we deal with ascites? Sure. So what is the doctor word for a tap? So pericentesis. So that's kind of like a Band-Aid, right? Somebody gets too much ascites, you stick a needle into them, and you let the ascites drain out. What about steady state? Are there ways that we can go about preventing the ascites to begin with? Furosemide, there's a more traditional drug that's used for that purpose. A different drug. Different diuretic. Spironolactone. What's the value of spironolactone? Of what? I am not aware of that function. It has to do with electrolytes. What electrolyte? Potassium, right? So what is aldosterone? What's it affect on?
It increases sodium retention, so you get rid of more potassium.
It's potassium sparing, right?
Aldosterone?
Well,
Yes.
The drug.
spironolactone.
Spironolactone. Yeah.
Aldosterone is spironolactone. Am I wrong?
No, she's related to aldosterone. She thought you meant.
Oh.
Yeah, I thought you were asking about
Aldosterone.
aldosterone.
Sorry.
Yeah, yes,
Aldosterone.
I got it.
So it's potassium sparing.
Yes,
So traditionally, because these folks have a tough time with electrolyte levels, the potassium sparing property of aldactone is. So what's the downside of Lasix? Right, it's a potassium waster. So increasingly we are seeing more cirrhotics on Lasix, but when I was training, that was not. They were not on Lasix. They were on aldactone or nothing. What about beta blockers? Beta blockers help with. Can help with the varices. Essentially, the idea is what you're trying to do is you're trying to decrease the portal hypertension, right? So let's talk about, since this is a bit of an aside, I digressed a little bit. Let's talk about the blood supply to the liver. What are the two structures that supply blood to the liver? Hepatic artery and the portal vein, right? So which one's more important? Portal vein, about how much of the blood supply comes from the portal vein? It's about 75%. So about 75% of the blood supply to the liver comes from the portal vein. So from the perspective of a surgeon, the two things that are most important to me are, number one, the coagulopathy, right? Is it present, and how severe is it? And number two, what is the platelet count, right? Not that the platelets have a massive role in hemostasis. They do certainly have a role in hemostasis, but more important to me is it is an indicator of how advanced their cirrhosis is. So somebody has a platelet count of 60. I am disinclined to operate on them, regardless of what their INR is. It's usually going to be high, but regardless of what their INR is, I am disinclined to operate on them because it suggests to me that they've got significant portal hypertension. So, and there are anatomic considerations there as well. So this portal hypertension, it's not just in the portal vein, as we already discussed. There's also increased pressure in the splenic vein and the SMV, and that's further distributed into the more downstream, right? So they can get these massive varices throughout the abdominal wall. They get them in the esophagus. What are the four areas where cirrhotics tend to get these portal venous dilations? So what do they call those? Caput medusae. We talked about the esophagus, gastric varices, sort of, right? What's the other one? So they get them in the rectum, and which hemorrhoids are associated with? Internal hemorrhoids, right? So internal hemorrhoids are associated with cirrhosis. External hemorrhoids are part of the systemic venous system, right? So we have a couple of scales that we can use in determining the prognosis or in predicting the surgical outcome for cirrhotics. So what are those scales? There's Child's Pugh scale and the MELD score, right? So which is the oldest? What's the traditional one? So it's the Child's Pugh score, right? So our Child's Pugh classification. How many different classifications are in the Child's Pugh classification? There are 3. So it's Child's A, Child's B, Child's C, right? What are the components of the Child's score? There's a fourth one.
Wait, I'll be.
Isn't it CMB?
Platelets aren't in it.
So it's another subjective assessment. It's not like you said that.
Ascites. Ascites is important. Ascites is a very important one. And I am highly unlikely to operate on anyone with ascites because it automatically. So the same numbers without ascites make that make you a Child's A, make you a Child's B, without or with the ascites. So ascites is important. So if you had to guess, what's the mortality of a child of any operation of some clipping the toenails of a patient with Child's A cirrhosis? That's obviously exaggeration. We're talking about an operation where they need anesthesia and you're going to make an incision on them. What's the surgical mortality of a Child's A? Nope.
10%.
It's 10%. So 10%, that's high. You know, there's not a single operation I do where I have even a 1% mortality rate. So the 10% is high. But if the problem is significant, you know, as long as the patient's well educated, understands that risk, I'm willing to operate in that setting. Child's B, what's the mortality? 30%. That is a 3-fold increase in the risk of mortality. And the only difference is the presence of ascites. And at that, it's just a small amount of ascites. Even a small amount of ascites confers that additional risk. So ascites is an important thing to consider, an important factor to consider when contemplating operating on cirrhotics. What's the mortality of a Child's C cirrhotic? It's 71%. I've heard as high as 80%. But if you use the MedCalc calculator, they give you a 71% mortality. So I've operated on Child's C cirrhotics twice. The first one was the lady I had no choice. She had ischemic colitis that perforated on me. And the conversation was, there's an 80% chance or whatever of you dying if I operate on you. there's a 100% chance of you dying if I don't operate on you. She was 48. So she said, well, gosh, I guess I'll take that 80%. And she made it about 2 weeks before she was unfortunately intubated. And once people with cirrhosis get intubated, there's a whole slew of new issues that open up. She made it an additional 2 weeks, and she died on about post-op day 28. And this was about the most meticulous operation I've ever. I took my senior partner with me, and we took our time. And anyone else, that patient would have gone home within a day or two. This patient, unfortunately, just did not have the reserve to recover from the operation. So the second time that it was an elective case, it was a hernia about the size of the one that we just did. And I warned him. He was having severe pain from this. It was recurrently incarcerating, and we get it back in. And he finally said, "Doc, you just got to fix this, please." And I said, "Here's the issue." So we sent him for an outpatient paracentesis. We had his ascites drained, so he was virtually ascites free. By the time he got to the operating room, his INR was a little about maybe 1.5, 1.6. Well, fairly regularly, particularly in trauma settings, 1.5, 1.6. That doesn't scare us. Anyone else, he goes home an hour after the surgery, that's fine. That gentleman spent 5 days in the hospital, and when he came to me in follow-up, he said, "Doc, I'm just not sure I knew what you meant when you told me this was going to be rough." And he said, I don't think I'd ever go. He had an inguinal hernia that he was, before surgery, he was saying, "I'm going to want you to fix this for me too." And I said, "Well, just get through this one." And afterwards, he said, "No, I don't want it. We're not doing that again." So it turns out, your liver is a very important organ to have functional when you're trying to recover from something like that, like an operation.
I'd argue that's the worst organ failure to have for surgery.
Yeah.
They have nothing to do.
Yeah.
No, I found out probably
I'm sorry, what was that you said?
a few weeks
I would
ago.
argue that if you had to pick one organ to have failure to be the worst for a surgeon, it's the liver.
It is.
That's anesthesia's problem. No, but I mean, yes, EF of 10% is probably not a great situation to be in. But other than that, you can ensure that the case is they'll recover from the surgery. That's my But there's another part of the science. It's all about pressure, right? It's not about the oncotic pressure. What's the other part of it?
We've already been discussing it.
Rhymes with choroidal hypertension.
Sounds like a band name. Schmortal hypertension.
Definitely a metal band.
Right. Did that answer your question?
Yeah. So it's hydrostatic also.
Say again.
It's hydrostatic pressure also.
Right. So it's the osmotic pressure
Yeah.
related to the lack of albumin,
Yeah.
as well as the presence of portal hypertension. So portal hypertension. Right. So MELD score. MELD score was originally designed for use in what? It was predictive of
What does it stand for?
Something about liver disease.
model of end-stage liver disease, and it was most useful to whom when it began?
Certain
Sort of.
subset. Transplant.
So it was designed for predicting who was most likely to be in need of liver transplant within the next year, right? And in the decades that have followed, there's been this massive controversy over which score should we be using as so non-transplant general surgery. Which score should we be using? And traditionally, it's been the Child's Pew score that's been winning that battle. That is changing. So which score appears to correlate better with with postoperative outcomes?
Smells.
It appears to be the MELD score. So the MELD score appears to have a better correlation with negative postoperative outcomes as opposed to the Child's Pew. That doesn't mean we're going to stop using the Child's Pew. But the advantage of the MELD score, so Child's Pew, you're basically taking a disease with a very broad spectrum, and you're trying to put it into three very neat and tidy categories. And it just doesn't quite work that way, right? So MELD score, you've got 0 all the way up to 45, I think, is maximum. I think at 47 or something, you're dead. But that is a much more specific way of categorizing people according to their level of liver dysfunction and physical fitness for surgery, if you will. So I haven't quite figured out how to integrate this into my own. For the sort of stuff that I do, I did bilateral shoulder lysis, not at the same time. We did one and then another one 4 months apart on a guy who was in my preoperative clinic note. He was a Child's B. In truth, during that operation, I took out 6 liters of ascites through his groin. So you could make an argument that he was probably pushing Child C, but his INR was only 1.2, so probably not a Child C. But that's a guy where maybe the MELD score would have been a little more useful to me, right? Because it doesn't take these broad strokes approaches to trying to fit everyone into these neat and tidy packages. So
There's some subjectivity too to quantifying the ascites and encephalopathy, no?
exactly.
So they do have some criteria to help you guide it, but to be honest, I don't know what exactly constitutes mild versus moderate versus severe ascites. Other than I know there's extremes, but
I think that might be all that I've got. Yeah. I don't think we need to beat this to death. We don't have to fill the full hour. Are there any questions? So the take home point here is that we can operate on cirrhotics, and they, much like people with cardiac disease, they can be optimized. So you can take someone. So can people be downclassed? They can, right? So I just told you the main difference between Child's A and Child's B is the presence of ascites. So how do you downclass them? Say again?
I was thinking paracentesis, but I was wondering, won't that...
Paracentesis is not, that's cheating, right? So I wouldn't downclass somebody on the basis they just got a paracentesis and we no longer see ascites.
That's what I was
That's not going to work. So right. So if they get started on spironolactone and their ascites goes away, I can now feel comfortable saying, you know what, I don't see any ascites. This is a cirrhotic who's been optimized. They're compensated now with assistance, of course, but they're now compensated. I'm comfortable saying this is Child's A, and I would say that person probably has a mortality risk closer to the 10%, not quite the 30%. So, what other sorts of steps can we take to improve outcomes when it comes to operating on cirrhotics?
You guys lifestyle modification stuff like low salt diet and no alcohol stuff.
Sure. So if you're cirrhotic, you shouldn't be drinking alcohol. There's no question about that. So, how much alcohol do you have to drink to become a cirrhotic? So it's all probably weight based, but in general, for men you need to drink about 60 grams a day for 10 years. For women, in general, you need to drink about 20 grams per day for about 10 years. It is a big difference. And how many people who drink that much will progress to cirrhosis? So it's about 5 to 40%. So like most things in surgery, when you get asked a question that seems way out of left field and not easily answerable, just say 30%, and you're probably pretty close. So
Wait, how is it 5 to 40? That's a lie.
so multiple studies, right?
Okay.
Multiple studies. Some studies report a rate of 40%. Some studies report a rate of 5%. So it's not a done deal, right? Most people will show evidence of fatty liver change after 10 years of drinking 60 or 20 for women. Only about 5 to 40% of those will progress to cirrhosis thereafter. What if you stop drinking then? Have you righted the ship? Can you still progress to cirrhosis? You can, right? So one of the most onerous aspects of cirrhosis is this whole concept of compensated cirrhosis versus decompensated cirrhosis. And all of us have had the misfortune of operating on somebody who we did not know that they had any issues with their liver because the labs were normal. There's no evidence anywhere that they had any liver issues. We get into their abdomen, we realize they've got a very nodular liver, and after surgery, it goes bad. It goes really bad. And so why does that happen?
Are you talking about during like OST and ALT, they kind of normalize after a certain period?
They do. What do we call that? We call it, so they've compensated for their cirrhosis, right? But the issue is that they have no reserve ability to handle any further stressing of their body, right? So you've now introduced a stress, the surgical procedure, and unfortunately you've thrown them over the threshold. And that has now taken them from a state where they were compensated to a state where they're decompensated. And suddenly they'll get, they'll get the jaundice, they'll get the fulminosities. What are the problems that cirrhotics may have that surgeons will get called about, but that we should not intervene on? We talked about one earlier. So pancreatitis, right? So it's not really a product of the cirrhosis itself. It is more a condition that tends to occur in the same setting as cirrhosis. So a lot of those folks will have chronic pancreatitis as well. And the pancreatitis is a separate disease process, but happens to occur at higher rates in people who are also cirrhosis because or have that cirrhosis because of alcoholism. But so we already mentioned one. One was SBP, right? So patient has signs of peritonitis, and we'll get a call that I think this patient has acute abdomen. You come and you find a tense abdomen, right? And ascites itself can make an abdomen tense, right? So at least once a month, I'll get someone in my clinic who's a cirrhotic, and they have a ventral hernia of some sort. They're big and distended, and I feel their belly is nice and tight, and it just has to be, it's got to be fixed, doc. My hernia is hurting me. What is my solution for those folks? What do I do for them? And their pain almost invariably goes away. Nope. Right. So I refer them for paracentesis, and I get them hooked up with somebody who's going to put them on aldactone, and we get their ascites under control, and that pain goes away. So so we actually have a name for that. We call it tense ascites, right? These folks feel rigid, and they are tender, and the solution for them is get rid of some of that ascites. That tension goes away, and the pain also goes away, right? So that ascites can put a lot of strain on their abdominal wall. What's another consequence of liver failure or cirrhosis? Happens oftentimes in acute liver failure. Something that happens to their kidneys. hepatorenal syndrome. And what is hepatorenal syndrome? So yes, you've touched on it. I think this sounds like something that Faith needs to end her rotation on by telling us about the mechanism behind hepatorenal syndrome in acute liver failure. Anything you want to add, or?
So that once you get hepatorenal syndrome, it's very on the side of your overall prognosis.
It's terrible. It's terrible prognosis.
In terms of giving you some sense of the scale from mold, 28 is the threshold to be listed. Or I'm sorry, to be listed really. Once you get to 28, you get exception points for being acutely sick and ill. So we know the 28 is they're highlighters. Quite safe. And then the only other thing would be regenerative capacity of a healthy liver. You take about 70 or 80% of the liver, and we're back. And within a period of less than a month, it's not enough.
You can only do that a certain amount of time before you get like a carcinoma or regeneration gap.
So it's an excellent point. So let's say somebody has an HCC, and they need a hepatectomy of some sort. How many segments does the liver have?
Well,
It's 8. Yeah. It's like it's back and forth.
It's 8.
O'clock,
Yeah.
right?
So there's 8. Yeah. That's right.
Yeah. It's like 1, 2, and then there's 2, 3, and then 2 4s, and then 5, 6, 7,
8 is your thumb.
Oh, 8 is.
8 is
one is your thumb.
one is your thumb.
I think,
Sorry.
right? Yeah.
One is
Okay.
your
I was like, I think I
If your thumb's like this, then
Yeah. Yeah. Oh, okay.
2, 3, 4, 8 would be 5, 6, 7. It takes a long time.
It does. It's a cool mnemonic though.
Yeah.
It really is a cool mnemonic. One of the better ones we've got. Basically, we then divide the liver in half. Right? There's a left hepatectomy. There's a right hepatectomy. And anatomically, we sort of separate into 3 different segments, right? Three different sections. So, say somebody has an HCC and they need some sort of liver resection, and let's say that tumor is big enough. So, if it's limited to only the right liver, then you could do a right hepatectomy, right? And that's all they need. And hopefully, that's curative. In many cases, it is. But what if that liver extends a little bit? So mostly right liver, but extends somewhat into the left. Are you done? You've got no options.
Transplant.
So transplant, but we're going to assume that transplant is not first line.
Being in line.
Can you still do the right hepatectomy and then go back to the right?
So no, what they'll do is they'll condition the liver, right? So they can make predictions. You can do a functional MRI and actually predict the residual capacity of the remaining liver. I don't remember how exactly they do it, but they can actually get hypertrophy. They selectively embolize segments of the target liver to get the left liver to hypertrophy. You can actually get enough regeneration of that liver that you can now do a safe hepatectomy based on increased residual function of the liver that you cause through embolization of selective. Yeah. So it's this is all liver surgery. This is all stuff that I don't want any part of. But
IR does that, right?
IR does it. Yeah. So you'll have these, and frequently it takes multiple trips to the IR suite where they'll do another functional MRI, make another prediction about the residual capacity of the liver. Do some more selective embolization, and eventually get to a point where, okay, it's now safe to proceed with an extended hepatectomy, and they'll have. And so we've spared a lot of people needing a liver transplant. Liver transplants are a very, very difficult operation. They're difficult preoperatively, they're difficult intraoperatively, and they are difficult postoperatively. So.
How long does it take usually to, on average, to do that, to regenerate all good enough?
Yeah, so it can take months, and this is part of the issue: is that you're dealing with cancer here. The good news about hepatocellular carcinoma, which is the most common primary tumor of the liver, the good news is that these are slow-growing tumors. They do metastasize. I have one patient that I've been. He's got a ventral hernia that we're gonna fix, but he's got lung mets that he's had for 2 years, and based on that, I initially said, "No way, man." And his transplant surgeon called me and said, "Hey, these patients can live a long time with these, right?" And with lung mets, guy has lung mets. He's got absolutely no decrease in his lung function. So I reached out to his oncologist. His oncologist said, "Yeah, I wouldn't be surprised if he lived 5 more years."
So it's more palliative. Just
He's got a big. So the problem is livers get put in through big incisions, and these are not. They don't have the best protoplasm, so they tend to form hernias. So I'm not sure I'd say what I do is palliative. I mean, it actually improves their lives substantially. But
Everything we do is
Yeah,
positive.
true.
yeah, I mean, everyone's dying, so in that respect, everything. But with any other cancer, somebody came to me with lung mets from colon cancer, and they've got a hernia. I'm probably not fixing that hernia. They're not going to make it very long, right? It's just not, because it takes a long time to recover from an abdominal wall reconstruction. But I reached out to the oncologist. The oncologist said, "Hey, yeah, he's doing great. I mean, these things are stable, and that's with minimal treatment." And this is someone who's immune suppressed because he had a liver transplant, right? So he is immune suppressed, and they're still saying, "Yeah, it could easily be 5 years. We just don't know. He looks great, And when I first met him, I first started treating him for somebody else had tried to fix his hernia, and they put in a big piece of mesh that subsequently got infected. They'd taken it out, and he developed a chronically infected wound. It turns out he's still got mesh in there, so that's part of the issue. We've resolved his infection, thank goodness, and just resolution. He looked like, in fact, the way I first got involved with him was I got a call from the oncologists, and they said, "We are concerned that this gentleman is going to die within the month if something's not done. Are you willing to give it a shot?" So we took him to the operating room, and we opened up his incision, got out all the mesh we could find, and left it open and vacked it for a week. Took him back, and everything looked clean, so we closed his incision again, and he did well. He healed. That was in September of last year. I saw him again last month, and he just looked like a new man. I mean, he's working again. He's put on a bunch of weight. I mean, he is really looking very, very robust and strong. Unfortunately, on examining him now, I can actually feel there's mesh still in there. So part of the reason why I've agreed to take a shot at fixing this hernia is because there's mesh in there that needs to go. So, okay.
Oh, I had a question. Sorry. So with ascites, could you give colloids or something like that, or albumin,
Right. So for example, this gentleman who I took 6 liters of ascites out through his groin, I immediately turned to into anesthesia, and I asked them to give what? I asked them to give salt pour out. So that volume has to be replaced, right? Otherwise, you've got to somehow increase their osmotic pressure, right?
Mm-hmm.
Best way to do that is through concentrated salt pore albumin. And so the way that I was taught, for every liter of ascites that you take out, you should give them 50 cc's of 25% spa. You can also do 250 cc's of 5% spa. That's a lot of volume. You know, you do have to be careful. You do have to be careful with their volume, and it doesn't quite have the osmotic pressure, right? Because it's dilute albumin, right? Whereas, you know, so yes, anytime you send somebody for a paracentesis, you really, I think IR has gotten really good about doing this in the recovery unit. But when I was a resident, whenever someone came back from an IR paracentesis, we always had to make sure that we replaced the effluent with an equivalent amount of spa. So,
The other thing would be ascites fistulas. So if you have an umbilical hernia, you have ascites, and eventually that skin's going to get tense and rupture. It's a huge problem, because now you've got a necrotic area that's infected, and they're a human water fountain. And those are extremely challenging patients to try to manage, because once you make a hole in the abdomen of the acidic, it's extremely difficult to get it to close. Hernias and cirrhotics are good.
okay, good. Well, we did. We filled an hour. For those of you watching at home, hang in there. Let's say it's the 23rd, so 1 week. Well, one week left. You'll make it, and